squamous as well as to adenocarcinoma of the esophagus. Stomach is the other cancer which you have because of smoking, and the treatment for this is, again, surgery is the mainstay of treatment for stomach cancer. If it's a distal portion of the stomach, you do what is called as a distal radical gastrectomy. You remove the 2/3 of the stomach as it is shown, and then you anastomose it with the jejunum, and you do what is called as a gastrojejunectomy. For a lesion which is proximal, that is in the upper part of the stomach near the fundus, what you do is a total gastrectomy, that you remove, cut at the esophagus, cut at the junction of the duodenum, remove the entire stomach, and you make a conduit out of the jejunum or the and do an anastomosis. So you can do what is a total or a partial gastrectomy depending on where the disease is, whether it's in the upper part or it's in the lower part or occupying the entire stomach. That will decide the amount of stomach that you're going to remove. If we coming to the next cancer, pancreatic carcinoma, it's said that 25% of the burden of pancreatic cancer is because of smoking, and cigarette smoking is an independent risk for pancreatic cancer. And if we look at the surgery, the commonest surgery that you do for pancreatic carcinoma is a Whipple's procedure, which involves removal of the distal stomach, the duodenum, the C of the duodenum, the first part of the jejunum, the head, and you cut at the neck of the pancreas that you remove, and the gallbladder and the bile duct. And then at the end you do a gastrojejunectomy, you do a choledocojejunectomy, and you do a pancreaticojejunectomy. You can also do a pancreaticogastrostomy, that is, you can then join to the stomach, the remaining pancreas, or to the jejunum. So this is the Whipple's. It's one of the most complex procedures. It takes average between 5 to 8 hours of surgery, depending on how you're getting a patient and what you find during the operation. And if the disease is not operable, as far as pancreatic cancer goes, it again has an extremely poor prognosis, between 15 to 20% 5-year survival for pancreatic cancer patients which undergo major resection. So one can realize that even with these complex surgeries lasting for long hours and modern treatment, the outcome is not something that we can really boast about. 15 to 20% 5-year survival is something for these cancers which is not great, but there can be improvement, but there has been a plateau on this because we are not making any headway. So the best thing again is if you can prevent a disease. This is a specimen where a pancreaticoduodenectomy has been done. This is the pancreas, there is the growth here, this is the jejunum, the gallbladder, and the bile duct. Liver cancer, again, because of smoking, it's a risk factor. Cirrhosis is the commonest reason because of which you have. And again, if you can do surgery, but very few patients with the hepatocellular carcinoma come for surgery. As of today, the modern treatment, the interventional radiologists carry out different different procedures for these patients. But if a disease, if it's in the left lobe, you do a left hepatectomy. If it's in the right, you do a right hepatectomy. And liver has this unique feature to regenerate. There's a causal relationship between smoking and liver cancer, and the risk of liver cancer increased with the duration of smoking or the number of cigarette smokes daily. And former smokers who had stopped smoking for more than 10 years, they have shown a decline in the liver cancer risk. So if you stop smoking, definitely the risk of cancer does go down. Colorectal cancers, again, if you have a cancer of the right side of the colon, you do a right hemicolectomy. If you have a left, you do a left hemicolectomy. If you're in the sigmoid, you do a sigmoid. If it's in the rectum, depending on where you have in the rectum, you do what we have classically been reading, which is abdominoperineal resection. Or if you can save the anus sphincter, you can do a coloanal anastomosis, or what is called as a low anterior resection. Smoking predisposes to development of polyps as well as cancers. Renal cell cancer, again, is a common cancer that you have because of the effect of smoking, and the renal cell carcinoma has this tendency to of throwing a thrombus, which is a tumor thrombus, going into the IVC, renal vein, and into the IVC. And it may not invade the wall of the IVC, it may just grow as a thrombus. So when you operate these patients, you can take a part of the IVC, make an opening, take the thrombus out. And the surgery that you do for these patients is a radical nephrectomy, that you have to remove it with the entire Gerota's fascia and all the contents inside it. You don't cut the fascia and get into it, because if you do, your chances are you're going to leave the tumor behind. If it's a small disease or a solitary kidney, then you can do a partial nephrectomy where you can save the kidney. So this is an operative photograph where one of our patients at Jodhpur had a right-sided renal cell carcinoma with getting into the IVC. If you can see, the IVC is bulged and swelling. They've taken a loop on the left renal vein, the right renal vein, and the artery has been there. And they've taken a part of the renal vein, removed the thrombus and the junction of the IVC, and you can see a stitch line without compromising the lumen of the IVC. These patients, even with a thrombus in the IVC, they tend to do well. They become a stage 3 cancer, but they still tend to do well. It's not that you cannot operate upon these patients. So early cancers, always, the outcome is excellent. In locally advanced disease, the survival decreases, but yes, you can operate upon them and technically remove the disease. Another problem because of smoking is the renal artery stenosis, where you can operate and put a renal artery graft, but I think the interventional radiologist can do this thing much better these days without operating on these patients by putting in a stent. Because of the atherosclerosis and the narrowing and the vasoconstriction it produces, it also produces thromboanginitis obliterans, and you may require amputation of the limbs or the toes in these people who are chronic smokers. Another cancer which is common because of smoking is the urinary bladder cancer. If it's early disease, you can do a transurethral resection of the tumor, and then you've got BCG or mitomycin and other things which you can instill. But tumors which are invading the wall, full thickness invasion, or involving multiple parts of the urinary bladder, you may land up what is doing is a total cystectomy, and then you create a neobladder. And this neobladder can be created from the colon or from the small intestine. And because of this, the entire urinary tract in your ureters are also, and at pelvis, renal pelvis is also at risk of developing transitional cell carcinoma of these sites. And when you create a neobladder, you can have it as continent, or you can have it through putting a thing in the sigmoid, which is incontinent. And these again surgeries take 7 to 8 hours, long operating time, involvement of different specialties, manpower, and it is a major drain on any healthcare system when you carry out these surgical treatments for these diseases. We have had a very excellent presentation by Dr. Agarwal about the on bones, and there's a study which is there that again on the tibial fractures, it says that 69% of the delayed union in smokers in tibial fractures because of the effect of smoking. Smoking and pregnancy, it affects the women in more than one ways, because it's difficulty in getting pregnant. The placenta separates from the womb too early, causing bleeding. Then there are complications during delivery, and you can have a greater chance of an ectopic. And on the baby, you can have premature, stillborn, infant death, and cleft lip and cleft palate can also be there. And about 6% of all the cleft lip or palate in the United States, it's been attributed because of the effect of smoking. And nearly 400 plus babies in the US are born because cleft lip of cleft palate because of smoking. And it drains nearly $40 million in treating these patients of cleft lip and cleft palate. Now this is something which requires surgery. No other treatment will correct it, and there are different procedures described for a cleft lip and cleft palate, and which require also the help of a speech therapist and other people from different specialities. Now what happens, these are just a few of the diseases that we have talked about, which have an effect on producing different cancers and diseases, and which can be managed surgically. If we look at the economics of it, it comes down to, for our country, it's around $6.6 billion worth of money which is wasted in different forms in treating these patients or these healthy individuals falling ill. And most of the cancers, we must remember, in our country develop a decade earlier than the West. So if you look in terms of life lost or of the hours of working lost or a productive life coming to an end, the number of years that somebody is going to lose out on is much more than what you have in the West. So if you quit smoking, then the risks decrease with time, especially for lung, mouth, throat and larynx. And within 5 years of quitting, the chance of getting cancer of the mouth and throat is cut down to half. And 10 years after quitting smoking, the risk of dying from lung cancer drops by half. So it's never too late to quit smoking. So whenever you decide, it's never too late. Don't feel that, well, I'm 50 or I'm 60, that if I quit smoking, nothing's going to happen, I've lived my life. Well, still the next 20, 30 years, it's going to make a difference in your life. So in the end, I would end with that, whenever you see a patient, or you must always ask about tobacco use. You must advise about users to quit. If you don't have the time as a clinician, I think you must send it across to somebody from the institution. Encourage them to get involved in this, where they can counsel. Assess the readiness to make a person quit, because again, people quit, as someone quoted from Mark Twain, that they quit 1,000 times. And you must assist with the quit attempt, and there has to be a follow-up care whenever we talk about whether the disease that you treat or the ill effect about smoking and how to give it up. And this is the just a photograph of the AIMS Jodhpur. Thank you so much.
Thank you, Professor Mishra, for giving nice talk on a wide perspective of surgery. And I think there may be many questions, clarifications. So this is time to ask. Yes.
Pass the mic.
So besides the question, you also tell your name.
Good afternoon, sir. Sir, I am Saurabh Verma from 5th semester MBBS 2014 batch. Sir, so due to high tobacco consumption, we all know that oral cancer is the most prevalent cancer. So, but after oral cancer, which is the most prevalent cancer, and especially in Rajasthan, that where the study is main going on, you are doing?
Oral cancer, then is the laryngeal cancers.
So,
Laryngeal cancers, hypopharynx, larynx, all these cancers.
so and what specifically about Rajasthan?
It's the same all over the country, no difference.
Okay, thank
Except
you,
in the northeast, where you have nasopharyngeal carcinoma in the head neck region is the commonest, but all over, it's the oral cancer and the laryngeal and the hypopharyngeal cancers which are common.
Okay, thank you, sir.
Yes, yes, yes.
Myself, Shashi Shekhar Dubey, MBS 3rd semester. So my question is there any link between PDA, patent ductus arteriosus, and smoking by pregnant women? Is there any link?
I have no idea about it. I have not read about it. They don't describe it.
It could be seen as study can be.
So I have not read about it as such. Anybody else who has some idea about it, but what I can say, I have not read about it, PDA and smoking.
I read one thing that the cortisol levels at the end of the 3rd trimester, they are released and PDA is prevented, and the type 2 pneumocytes are activated under influence of cortisol. But once I read that smoking reduces the level of cortisol, so it could be.
I have no idea. Somebody can answer that. That we could.
Such studies are not there. You see, it is related to the prostaglandin. and prostaglandin synthesis is inhibited by glucocorticoids. This is a known fact. So that can be working, this interrelationship. But whether this relationship has got a relationship with the smoking, it is not known.
I must compliment you on your diverse reading in third semester.
I read in Leninger actually.
Please pass the mic.
See, the PDA is a structure that is always there in the body. So it's not an anomaly. It gets obliterated after birth.
Then it is a
Okay. So if the stimulators are not there for its obliteration, in that case, it remains patent. Or wherever it is required, say like say so many patients are there, children are there, who are dependent on PDA because of malformation in the heart. So in all those cases, PDA will remain. So PDA is not an anomaly. Like say when you say cleft lip or cleft palate, they are the anomalies. Okay, but PDA is normally there. In all of us, it is there during gestation. But once you are born, it gets obliterated by normal existing mechanisms. Okay. So in those cases where those mechanisms are not well developed or oxygenation at the time of birth is not really good, those are the cases where it remains open. So I don't think it has got any correlation with the smoking in mothers. Okay.
Right, sir.
Thank you, Dr.